Good day and welcome to Myositis Support and Understanding. My name is Jerry Williams. I'm the founder and president of Myositis Support and Understanding. Also joining me today from the MSU team are Lynn Wilson, our vice president and director of patient-centered research, and Manuel Lubinas, our chief science officer. We are excited for today's webinar, Intravenous Immune Globulin, IVIg, a newly approved therapeutic option for the treatment of adult dermatomyositis. And we are excited to welcome Dr. Rohit Aggarwal back for this presentation. And many thanks to Octapharma for sponsoring this educational event. Today, you'll get an opportunity to learn more about Octapharma's IVIg therapy and results of the landmark Progress in Dermatomyositis, or ProDERM study. The successful ProDERM study resulted in the first and only FDA-approved IVIg therapy for dermatomyositis in adults. And that's what we'll learn about today. Many of you already know him from past events, and we are excited to welcome him back, Dr. Rohit Aggarwal. Dr. Aggarwal is a professor of medicine at the University of Pittsburgh and medical director of the Arthritis and Autoimmunity Center at the University of Pittsburgh Medical Center. He is the co-director of the UPMC Myositis Center, and his research and clinical areas of interest are clinical and translational research in inflammatory muscle diseases, or myositis, and associated interstitial lung disease. Dr. Aggarwal, thank you for joining us today, and we look forward to your presentation and discussion.
So today we'll be talking about Octagam IVIg 10%, in its role in dermatomyositis. So let me see here. Okay, here are my disclosures. I wanted to let everybody know that the talk and the study was sponsored by the Octapharma. I'm on advisory board of Octapharma, medical advisory board and consultant for Octapharma and various other pharmaceutical companies that are working in the field of myositis. I have received research grants from various different pharmaceutical companies. So for this Octagam 10%, it's IVIg. Basically, it's an approved treatment up until now, was approved for chronic ITP for adults. And just recently in June 2021, we got an approval for use in adult dermatomyositis as well. Here's what we call as black box warning. There are three things listed here. The most important thing that I wanted to pay attention is thrombosis, which basically means blood clot formation. And people who have high risk for blood clot formation or have had blood clot formation, there's a caution for them to use IVIg. The second thing that is listed typically is kidney problems. And I have to say that I haven't personally encountered any kidney problem. It certainly is listed and is seen in studies. But most recent study, we haven't seen much of the kidney problem. Partly it is to do that the nowadays new formulations does not contain the products or what we call as the adjuvants that could harm kidneys. And then I think the last is basically essentially the repeat of the same thing: thrombosis, renal, kidney function problems, and so on. So moving forward, so first I will give you a little bit of introduction of dermatomyositis. I understand that you already know all of this probably, but before I get into the IVIg, role of IVIg in dermatomyositis and the study results, I think it's good to discuss a little bit of understanding about myositis. So myositis, basically, we also call myositis as idiopathic inflammatory myopathy, and you may hear the term IIM, which basically is idiopathic inflammatory myopathy, which is characterized by inflammation in muscle and or skin. In dermatomyositis specifically is muscle and skin. Dermato means skin, myo means muscle, and itis means inflammation. And basically, most of our patients have proximal muscle weakness. That means they have difficulty in getting up from a chair, lifting their hands over the shoulder, or lifting anything heavy. And they also, in case of dermatomyositis, have typical skin rashes of dermatomyositis. As most of the patients already have appreciated, that no two patients look alike. Every patient is very different from each other. So it's a very heterogeneous disease. Some patient may have lung involvement. Others may have involvement of their heart, other may have involvement of their joints. So it's a very heterogeneous disease, although most have muscle and or skin involvement. And its classification or subcategory of dermatomyositis is based on various different things, such as some patients may be characterized by their autoantibody. I saw a chat box saying that I have anti-MDA5 antibody. That's an autoantibody. So you can subgroup dermatomyositis by autoantibody. You can subgroup by severity, mild, moderate, or severe, or you could subgroup by number or different organ involvement. For example, dermatomyositis with interstitial lung disease or without interstitial lung disease, and so on. So who gets affected with dermatomyositis typically is more females than male. I would say about 70% are female, 20-25%, 30% is males, which is very common for any autoimmune disease, by the way. It affects two age population. One is it can affect kids, typically between 5 to 15 years of age. And then it affects adults. Any adult can be affected, but most common age range is between 40 to 60. Also, the incidence is 10 cases per million person per year, and the prevalence is 125 cases per 1 million person, which basically roughly translates about 50 to 70,000 patients in US. So overall, if you look at the US population, about 50 to 70,000 patients of dermatomyositis lives in US. So I think that's, it says here, 41,000 living dermatomyositis and 3,200 every year are diagnosed. So now going into a little bit more clinical features, as we've talked about, these patients have weakness, muscle weakness, especially of the shoulder girdle and the hip girdle, and the core muscles are weak. They get typical rashes, like we call them heliotrope rash, which is rash on the upper eyelids, V-sign rash on the upper chest, shawl sign on upper back, and Gottron papules, which is on the back of the hand. Those are the main characteristic rashes. There are several other rashes as well. Now, we talked a little bit about myositis-specific antibodies. In dermatomyositis specifically, we see 5 different autoantibodies. One is anti-MI2, which is actually a good antibody to have. Anti-MDA5, again, a bad antibody to have because of association with interstitial lung disease. TIF1 gamma antibody, it could be bad if there is association of cancer, or it could be good if the patient is younger, and in that case, they don't have cancer in most cases. And NXP2 is sort of a medium prognosis antibody with some risk of cancer and some risk of being refractory disease. And there's another antibody, anti-SAE, which is not that common.
Dr. Aggarwal, can I ask,
yes.
may I ask a question on that
yes.
slide? Do you mind going back one? Yes. So on the anti-TIF, it says muscle biopsy specific features. Are those things that that doctors know is that a special test that has to be ordered on the muscle biopsy, or is that shown in a journal?
So the specific muscle biopsy features they're talking about is more very specialized centers can recognize those features. So typically, I would probably should even be taken out because most people don't have access to those centers. Right. You're talking about a couple of centers in the country.
Gotcha. Thank you.
So yeah, it's very difficult to recognize those features. So I wouldn't rely on that. Okay, so now coming to the study, this ProDERM study, or Progress in Dermatomyositis study. First of all, I want to thank Octapharma for doing this study. This was a much needed study because most rheumatologists, neurologists who treat myositis believed, even before the study, that the drug works. The problem was the lack of confidence. Like, I knew the drug works, but I wasn't 100% sure. Or I didn't know what exact population it would work. And I wasn't even clearly sure about the safety profile overall in myositis patient. So this study, and also it wasn't FDA approved. So because it's not FDA approved, when I would order this drug for my patients, sometimes it will get approved, but many times it will get rejected. So that's why the study was very important. This was a prospective double-blind, randomized, placebo-controlled, multi-center study to evaluate safety and efficacy of Octagam. So this was a 16-week study in which it was a 16-week double-blind placebo-controlled study. That means half the patient got drug and half got placebo for 16 weeks, followed by 24-week where everybody got the drug. Was conducted around 36 sites worldwide, 17 sites in US. We enrolled 95 dermatomyositis patients from age ranges 22 to 79. And was mean age of around 53 or 54, and mostly females and mostly Caucasians. In this study, basically, most patients were already have received treatment with corticosteroids and other immune suppressive drugs. So these patients have failed to some extent the steroid and another immune suppressive drug, or were intolerant to those drugs before they got into the study. All right. So the primary and secondary objective was to show that the proportion of responders to this 2 gram per kilogram IVIg dose of Octagam 10% and placebo at week 16 compared to baseline based on the total improvement score was more in Octagam as compared to placebo. So that was the objective, that the number of patients who responded to Octagam should be significantly more to the number of patients who responded to placebo arm at week 16. And there were many secondary endpoints, which means that we looked at their muscle, we looked at their muscle enzyme, we looked at their skin through a score of called CDASI, and we looked at the safety and tolerability as well. So the primary outcome measure was this something called TIS, Total Improvement Score. This was used to ascertain whether the patient has responded or not. And it's a scale of 0 to 100 score. If you have had more than 20 points on this scale of total improvement score, it's considered to be minimal improvement. If you have more than 40 points, then you consider to have moderate improvement. And if you are more than 60 points, you consider to have major improvement. And the scale is made up of 6 specific assessments that we do on our patients. Number 1 is physician global assessment, which basically done as a part of a tool called Myositis Disease Assessment Activity Tool, where physician will go over each and every organ of the patient and assess overall disease activity. Patient global disease activity, which is also a tool where patient is asked, how active do you think your disease is on a scale of 0 to 10? MMT, or manual muscle testing, where we test patient's muscle, we press on patient's muscle and see how strong they are. Health assessment questionnaire is a patient-reported measure that is done by the patient to assess how do they feel their overall health is. Muscle enzyme, as you may already know, many of our patients have elevated muscle enzyme. So those are assessed. And last but not the least, extramuscular activity, which means apart from muscle, what else, what other organs are involved, like skin? And then you have to score that as well.
And I think there's an educational moment right there. The last point on your previous slide there, sometimes, the number 5 about the muscle enzymes. We hear this in our groups a lot, that even some doctors don't realize that, the liver enzyme test is poorly named, and can actually, those can be, associated with the muscle breakdown. So I think that's important to highlight to those that are patients.
Yeah. In fact, I would say that once a year, I see a patient who comes to me after having a liver biopsy, because their doctor had liver function abnormality on the patient, and they kept focusing on liver when the problem was actually muscle, because it's the same enzyme that we check for liver, and the same enzyme is elevated in myositis. So these are actually called liver enzymes. So, but most doctors forget that these same liver enzyme also comes from muscle.
Yes, thank you.
So we enroll patients from age 18 to 80 with the definite or probable diagnosis of dermatomyositis according to a criteria called Bowen and Peter criteria. We looked at each and every patient independently and made sure that they have active disease before they enter the study. They had to fail a previous immune suppressive drug or intolerant to previous immune suppressive drug or be on current standard of immune suppressive drug. They have to have weakness. So they have MMT score or manual muscle testing, which is a strength of testing of the muscle strength. Score has to be less than 142 by 150 with at least 2 other abnormal core set measures. And those were patient global, physician global, extramuscular global, at least one of the muscle enzyme being abnormal, and hack assessment being abnormal. So now coming to the study design, what we did is we screened a lot of patients, then we randomized those patients into 1:1. Half the patient got IVIg at 2 grams per kilogram every 4 weeks from week 0 to week 16. Another group got placebo infusion every 4 weeks from week 0 to week 16. If at 8 weeks or later, you're actually getting worse, which is called as confirmed deterioration. If you're deteriorating, what we do is you switch the group. So if they're on IVIg, you change them to placebo. If they're on placebo, you change them to IVIg. The rationale being why to keep them in the same arm if they're not really improving or actually getting worse. Now at week 16, everybody started getting the same dose and the same drug, IVIg. Some patients at week 28 were allowed to have dose reduction of IVIg to 1 gram per kilogram every 4 weeks, if required, or if thought to be right by their doctors. So the results. So we screened 126 patients and randomized and treated 47 patients with IVIg, randomized and treated 48 patients with placebo, and 97.5% patients completed the first phase of the study, and 72% patients completed the extension phase of the study. So one thing I always point out, when somebody then 95% patient completes the study, that means the study was done well, and that means the drug wasn't causing major side effect because the patient kind of stayed in the study. So some basic results, basically their mean age was 54, mostly 76% were female, 92% were Caucasians. Now, this is the most important aspect of the study, which is the primary outcome was the total improvement score of more than 20 points. And this was achieved by 78.7% in Octagam 10% versus only 43.8% in the placebo, being highly clinically and statistically significant result with a delta of 35%, which means the difference between the placebo and the treatment was 35%. We typically say a delta of more than 20 is enough. And here we had a delta of about 35. So clearly Octagam 10% showed significant improvement as compared to placebo. But this was a minimal improvement. As I remember, TIS score here was supposed to be above 20. So the requirement was very low. So that's why you also see very high placebo rates. But for me personally, the more important result is moderate improvement, because this is hard to achieve through placebo. Even then, 22% patients achieve moderate improvement. But look at 68% patients achieve moderate improvement in treatment arm with a delta of 45% with a highly statistically significant results. And a major improvement is typically very difficult to get, especially very difficult to get within 16 weeks. But about 32% patient had major improvement, and about 8% patient had milder improvement with the placebo. Overall, at the end of the study, if you look at about 70% patients got better, regardless if you were on Octagam or if you were on placebo first and then got Octagam, about overall 70% patients got better. Now, this is a good graph because this shows a mean total improvement score here on the y-axis and the time on x-axis. And these blue lines and dots represents the IVIg. So if you see how IVIg treatment patients got better rather quickly, but the placebo treatment patient did not get better initially. But when the placebo treatment patient got IVIg, they improved dramatically as well. And they continued to improve all the way up to 40 weeks. Now, these results show what about the skin improvement? The skin is measured by something called CDASI, which is, I forgot the exact name, but clinical cutaneous disease activity assessment severity index is what it means, which basically means skin disease activity on a scale here. If you see, everybody started around 20, but the patients who got IVIg improved quickly on the blue line, and they continued to improve. The patient who got placebo didn't improve that much, but then improved dramatically after they got IVIg. So clearly, it's different, significant improvement in skin as well, not only just muscle or overall disease. What about some side effects? So many patients experience a lot of side effects, but I'll want to go over that because I think side effects is often one of the major concerns of our patients. So what happened in the study was about 65% patient got some side effects, okay? Now, but most of these side effects were kind of mild, but let's see what type of side effects were there. So this table suggests any side effect that was more than 5%. Headaches, fever, and nausea. Those were by far the most common side effects with IVIg. Some patient gets vomiting, chills, musculoskeletal pain, and increase in the blood pressure. But by far, if you have to remember, 3 side effects is headache, low-grade fever, and nausea. But let me go back to it again. But I think I want to make 2 points here. That even though these frequencies seems to be high, that headache about 40%, but I want to make few points that most of the severity of these headache, fever, and nausea were mild. So about 70% side effects were mild, about 20% were moderate, and about 10% were severe. So that's an important point to remember. The second point that I always emphasize is these side effects were infusion related. That means for the 2 to 5 days out of the month when patient is getting the infusion, that's when most of these side effects are occurring. But beyond the infusion, so the rest of the 20-25 days, patients are not really experiencing these side effects. So that's another thing. When I tell my patient to start IVIg and they have a little headache, I ask them how severe it is, and once I tell them it's going to last only for a few days, then most of them are pretty okay with it. Now, there were some serious adverse events. I think this is also important, but the serious adverse event frequency was similar in Octagam and placebo patients. Overall, 5 patients developed serious adverse event, and most of these serious adverse events were related to thrombosis, the deep vein thrombosis, pulmonary embolism, cerebrovascular accident, which is another name for stroke, cerebral infarction, which is another type of stroke, hypoesthesia, which means decrease in sensation, again related to stroke, and PE, pulmonary embolism in one subject. So what happened is that around somewhere in the study, we realized that some of our patients getting serious adverse event, and most of those serious adverse events were thromboembolic in nature, which means they were due to clotting, blood clot formation, or thrombosis. So we talked to the FDA, and FDA back and forth, we decided to decrease the overall rate of infusion, or the maximum rate of infusion. So that means how much drug goes in your body in what time span, that rate was decreased. So if a patient was getting an infusion in 4 hours, now they're going to get infusion in 6 hours or 8 hours, depends on the patient's situation. So it would take longer to infuse the drug. The amount of the drug is the same. It's just how fast you give the drug. So what we realized is that maybe we're giving it too fast. And then we cut down the maximum rate of infusion. And what we saw is once we cut down the maximum rate of infusion, the risk of blood clot formation was almost decreased into 1/3. So that was the main lesson that we learned, that drug is to be given slowly to prevent any blood clot formation. Now, there are some aspects that you need to understand. This is not just the drug. The drug can lead to increased blood clot formation, but the disease itself, dermatomyositis, the active dermatomyositis itself causes thrombosis or deep vein thrombosis or pulmonary embolism or stroke or heart attack and things like that. So baseline, the disease itself has higher risk, and when you add a little bit more risk of IVIg, it can be a problem. But the lesson learned is there's probably much less of a problem if we don't give it to a very high risk patient for clotting. So if somebody has had a PE or pulmonary embolism, or a recent heart attack or stroke, or deep vein thrombosis, I may want to avoid IVIg in those patients. That's number one. Number two, even in the patient who seems reasonable and doesn't have high risk factor for blood clot formation, even then, I think we should decrease the maximum rate of infusion to 0.04 ml per kilogram per month. So in summary, primary endpoint of the study was met with significantly higher proportion of responders in Octagam group as compared to placebo group. Patients had significant, moderate, and major improvement as well. Safety profile was acceptable in terms of almost like an expected range for IVIg through other studies, with headache, fever, and nausea being the most common. And this is the first large placebo-controlled study which proves efficacy and safety of IVIg in dermatomyositis, leading to an FDA approval of IVIg in dermatomyositis. The importance of the study is really much more than what I just said. It's quite important to get an FDA approval through a study, but more importantly, this creates a pathway for other therapies in future, if they're good and they're efficacious and safe for a patient, to get approval through FDA. With that, I would, this is just a prescribing information warning. And with that, I would thank you and would be happy to take any questions.
Great. Thank you so much, Dr. Aggarwal. Wonderful presentation and great information, and some wonderful highlights on what dermatomyositis is and how heterogeneous it is, and how the presentation. So congrats to you and to Octapharma and getting this FDA approved. It's not an easy task for sure.
Yeah.
We do have some questions. Lynn and Manuel, I don't know if have you been monitoring the chat? Would you like to?
Yes, I'll go ahead and start. Yeah, we have a few questions here, Dr. Aggarwal. Number one from Allison: what qualifies a patient for this treatment? I have MDA5 with ILD. My Duke doctor said I didn't qualify. Why?
Yeah, I'm not sure. But what qualifies you for the treatment is having active dermatomyositis. So what does that mean? Active dermatomyositis means that you have active muscle inflammation leading to weakness, or active muscle or skin inflammation leading to skin rashes. That's what qualifies to have active dermatomyositis. And if you have active dermatomyositis, this treatment could be given to you.
Okay, thank you. She also has another question, and I'll just take hers next.
Sure.
The second question is, should patients with DM, and she's speaking about MDA5, with muscle weakness get a muscle biopsy?
Yeah, well, that depends on how certain is your diagnosis. If you have an anti-MDA5 antibody, and you have typical skin rashes recognized by a trained rheumatologist or neurologist or dermatologist, you may not need muscle biopsy necessarily. We do muscle biopsies on all our patients because of our interest, and we're trying to understand how does muscle biopsy help us. But not all cases of classic dermatomyositis, especially if they're antibody positive, needs muscle biopsy.
Okay, thank you. Now, this is a question that we hear a lot of, and this is from Michael, and that's that I once heard that if you have an antibody, you're always going to have it, you'll test positive. I tested positive for TIF1 gamma, but on the first test, but not on the second test.
Yeah, that happens.
Why does that happen?
Yeah, that happens because of the test is highly variable. We don't have good tests. We don't have very reliable, consistent tests. So what happens typically is that the second test wasn't done right, or was unable to detect it. Maybe there were two different tests. Even if it's the same test, it could be one of the common reasons the test not done right, because the autoantibodies typically stay positive. Now, having said that, we do see decrease in the level of autoantibody once the patients are better. And occasionally, or sometimes, patients do go negative. So it could be a case that your levels were very high, so it was easily detected. Then you got better. The levels went down, but still positive. But now the test not able to detect it. That's could be another explanation.
Okay, thank you. Next one from Michael also is do you believe ProDERM is more effective than other IVIg treatments like Parenza?
No, I don't believe so. I don't believe so. Again, it's very difficult to say more effective or less effective or equally effective without doing a head-to-head clinical trial. Like you have to do a study where you give IVIg and then you give Subiqg IG and see which one is better. I don't think I can say that. I don't think anybody can say that. I can say that the Subiqg IG is also seemingly effective in dermatomyositis. Having said that, they haven't completed the clinical trial to prove it.
And one last question from Michael about since ProDERM is FDA approved, will this make it easier to get approval by insurance?
Absolutely, yes, because by law, if your insurance company can say that you have to first fail X, Y, and Z, then I will give you IVIg. But they cannot refuse IVIg. Like they can't say, we will never give you IVIg. Do you see what I'm saying? They can create some clauses before they get you to IVIg. But once the drug is FDA approved, they cannot deny you that drug.
And his follow-up to that is he's transitioning to Medicare. Do you have success with it being covered?
Yes,
IVIg?
absolutely. Absolutely. For dermatomyositis, yes.
Okay, thank you. We have one from, a couple more here, one from Imran. How many dermatomyositis cases actually end up in a dermatology clinic due to the rash?
I mean, there are a few. I get referral commonly from my dermatology colleagues. When they see a dermatomyositis rash, they would refer the patient to me. But the patient first was seen by dermatologist because of the rash. And that happens. I mean, it's tough to say how many cases, but I mean, I think this scenario happens about 10-20% of time.
Okay, thank you. And the last question that I see here is, are there other brands of IVIg used for DM that are already FDA approved?
No, the only brand that is FDA approved for IVIg is Octapharma, and other IVIg drugs cannot market their drug for dermatomyositis. Okay, go ahead, Manu.
Yeah, so I think one of the questions that was submitted before was, how long should this treatment last? Is this a treatment that you do for a couple of years, a few years?
Yeah, it's different for everybody, but on an average, the way I give this treatment is I give it once a month for 3 to 6 months, okay? And then I, at 2 grams per kilogram, and then I decrease the dose to 1 gram per kilogram, again once a month for another 3 to 6 months. And then I decrease it to every other month, 1 gram per kilogram for 2 or 3 cycles. And then I would stop it, or sometime I go to every 3 months and then stop it. So in a best case scenario, it takes about 12 months. On an average scenario, it takes about 15 to 18 months. But there are some patients who are on it for years, because anytime they cut that down, their disease come back, and that happens. However, I have to say, it seems like Rebecca had a question where she was doing fine, and her doctor start to space IVIg, and her CK starts to climb. I always tell people and doctor that climbing CK is not a problem, because once you stop the drug or space out the drug, the CK will tend to climb. The question is, are you seeing the muscle weakness as well or not? Because if you're not seeing the muscle weakness, little bit of CK increase is not a big deal. In fact, that's going to happen.
Good.
Yeah, I think the other question I had from previously that I was sent is like, how do you combine this therapy with the other treatments, right? Some of these patients are taking Rituxan, methotrexate. What exactly is the right combination with the other medicines they're receiving right now?
That's a great question. So good thing with IVIg, it can be combined with any other treatment. And that's the reason behind that is because IVIg does not suppress the immune system. So the way it works is not through immune suppression. So any other drug like rituximab, methotrexate, mycophenolate, you could easily combine with IVIg without any problem.
And the other question I think that comes often sometimes here is this question from Bailey about the Subiqg IG and what kind of the differences between Subiqg IG and IVIg, and will they get an FDA approval for that, if you know?
Yeah, so there is a clinical trial going on Subiqg IG, which if it's positive will go through FDA approval. But the point here is, I told you that in my experience, Subiqg IG works. What I don't know how well it works. What are the advantages of that as compared to IVIg? One of the advantages that is thought that maybe Subiqg IG would have less serious side effects or less blood clot problem, but we don't know that for sure. But that's one of the proposed advantages. So I think the drug works, but how well it works, how much it works, and what's the safety profile and tolerance profile, I think that's yet to be seen.
And Lauren has a question about the pharmacokinetics, I think, of IVIg, and it's, what is the ideal IG trough that you look at for high dose IVIg, or is something that you even look at that?
We don't look at the trough or lower level. What happens is once you give IVIg, the IVIg levels go really high, and then it slowly declines, and then it declines to about 4 weeks, and then you get another one. So it's sort of the way it works is go up, down, like that. And that's one of the reasons people believe maybe Subiqg IG is good, because it kind of goes up and then stays up. But again, these are all theories. There's no way to know until we have a trial that shows that it works.
And I think Vanessa has an interesting question about patient advocacy. It's like, what do you recommend if the doctor does not want to allow this treatment and the patient wants this treatment?
Say that again. I didn't understand that question.
Yeah, Vanessa says, what do you recommend if the doctor does not recommend to allow this treatment for XYZ reason? Do you think that patient should do something about that?
Well, are you saying that the doctor is not recommending this treatment and the patient wants a treatment? Well, the patient should talk to the doctor. What about this treatment? This is an FDA-approved treatment. Can I get that? And if not, why not? There may be reasons that the doctor knows that is not a good treatment for you.
Yeah.
Like, for example, if somebody just had an stroke, I would not give this drug to that patient.
Correct. So there are things that should be considered before they act. So good discussion and good communication with the doctor is always essential.
Yep.
So I have Crystal Klein is saying, I have polymyositis, but started IVIg for calcinosis, cutis skin ulcers. Are there any studies or headways to the FDA approval for this type of treatment for calcinosis cutis?
That's a very good question. In fact, calcinosis cutis is the most difficult manifestation to treat for dermatomyositis, and I do believe IVIg works for it. The problem is it doesn't work excellent. Like it's sort of the way I see IVIg for calcinosis cutis, it sort of stabilizes it, prevents it from worsening. Does it get better? I don't think so. So what it does is it stops the disease activity that then prevents worsening or more calcinosis, but it doesn't improve it. So we don't really have very good and effective treatment for calcinosis cutis.
This is
I had a question here from IBM patient. I have not said, does it help IBM patients in any kind of circumstance of symptoms for IBM patients, you know?
Say that again, does it help IBM patient? Okay.
Correct.
Now, this is a most controversial area, so I have to be careful what I say. There are some doctors who believe IVIg works for IBM. However, when you talk to them, what they believe is it works for IBM in stabilizing or preventing further worsening. So what they're saying is it doesn't improve IBM, but it may slow down the progression of IBM. Okay, so that's why some doctor, including myself, sometimes would give IVIg as a treatment for IBM. And then there is a whole other, big lobby of doctors who don't believe in IVIg for IBM, and they would not prescribe IVIg for IBM. So those, I just wanted to give you the, the part of the problem is there are studies done on IVIg in IBM that showed that there was no improvement. However, the criticism of those studies, those were very short studies. And in IBM is a long-term disease. So if you do a 6-month outcome in IBM is not meaningful. So one of the idea is perhaps to do longer studies, and then it may show an improvement. So that's the point I was trying to say, that it's not clear cut basically.
Yeah, and I think I have seen in the groups patients that claim that in IBM that helps them with the dysphagia or XYZ symptoms specifically. So, but there is no clinical evidence of any of those at this time, right?
Yeah.
We did have a few more here, I think, and if you've already answered this, I apologize. But Elliot asked a question, which is always a good one. How often are antibody tests negative?
Yeah, so about 30% of patients does not have a recognizable antibody, and that's in a good center like ours. Commercially, I think the frequency of autoantibody negative may be even more, maybe 35 to 40%. So, keep that in mind, those two things in mind, that in our lab, in our hands, about 70% patient have an autoantibody positive. So one more thing I wanted to say that I know nobody has asked any COVID question, but I know this comes up all the time. So I want to mention that IVIg is perfectly safe in COVID and has no problems. Like, some immune suppressive drugs, it could be a problem in your vaccination response, or could make you predisposed to getting COVID. IVIg has none of those problems. In fact, IVIg is somewhat protective because IVIg may already have an antibodies against COVID. So once you get IVIg, you're sort of getting other antibodies that could be there. And with that, I also want to, basically appeal our patients to see if they're willing. I know MSU has partnered with COVID study and has disseminated the COVID survey in past, but I want to make a personal appeal to all those who are listening. If they could do the COVID vaccine survey that we are doing on our myositis patients, so that we can get more data on safety of COVID vaccines in myositis and other autoimmune diseases, that would be very helpful. And I know, I think you've already posted those links into the patient, portals and stuff, but I will just post that here. If somebody wants to take that survey, it would be very helpful for us to understand the long-term effects of COVID. So I just posted to all the hosts. If they would want to take the survey, it will be very helpful.
I was frantically trying to find the link as you were talking, so thank you.
Yeah, so was I.
Where'd it go?
We were all trying to find the link. Yes.
Yeah, no, I posted the link, and I would request all the participants, if they could take the survey, that would be very helpful for myositis researchers to understand the long-term effects of COVID vaccines and its safety and stuff, and COVID.
Yes, important call to
action. And you can have your family members do that, because we need autoimmune and myositis patients, but we also need non-myositis patients to compare.
Okay, everybody hear that? Let's get everybody filling out that survey, hand it off to your friends your families, or healthy friends even. Like you said, we need healthy people involved in the study too. So thank you for sharing that again with the community, Dr. Aggarwal. We will not let you down, right, guys? All right. Did anybody have any other I think there was a question Jason had asked. I don't know that we addressed this one but how long do you stick with IVIg if you're not seeing improvement?
Oh, that's a very good question, because if I'm not seeing any improvement by 4th month, like 3 doses, so at least 3 doses done, and another month, I say that because I need to see the effect of that 3rd dose. So total of about 3 to 4 months. If no effect, I would move on.
Excellent, thank you. And thank you, Jason, for your patience in getting to that question. So thank you, Dr. Aggarwal, again,
Sure.
for all of your wonderful expertise and for sharing this interesting data with us, a tool now that you guys have to help treat us. And thank you. And thank
Sure.
you to
Thank you.
Octapharma for sponsoring this event. We appreciate that. And I just also want to say that the annual virtual patient 360 conference with IGNS is coming up in May, and that is free for patients and caregivers to attend. It's on May 21st and 22nd, and it's all about IG therapy, IVIg, Subiqg, and many other topics as they address to living life with myositis and other autoimmune diseases. So I will post that information if you're interested in registering. Again, it is free for patients and caregivers to attend. So thank you. Anybody, Lynn, Manuel, or Dr. Aggarwal, any final comments before we close out for the day?
No, thank you very much for inviting, and thank you for listening to this talk. As I tell patients that it's really important for patients to participate in research, these surveys and patient activities, because we cannot learn if the patients don't participate. The only way we learn is for patient. When patient participate, we learn from the data, and then we can tell back to the patients.
Yes, absolutely. We try to encourage everyone that's able to be a part of clinical research in some way, and we offer so many opportunities for you to be a part of that, whether it's a traditional clinical trial or other type of study where you're sharing your voice as a patient, like we are, here at MSU. So thank you, and the patient-centeredness is, very well received from you, that you truly care about your patients, and it comes through. And it means a lot, and it helps people keep motivated, to keep helping because you care. So thank you again. Everybody have a wonderful day. And if you have any questions, again, you can contact us at MSU. And we also posted the number for the Octapharma Support Center, where you can, if you have questions later, you can contact them. Their number is in the chat, but it's 800-554-4440. So again, thank you. Have a wonderful rest of your day.